We will learn about the increased intracranial pressure this afternoon. ICP is a syndrome throughout our neurosurgery learning and also a clinical syndrome associated with neurosurgical diseases. The lecture will be delivered from this concept: regulation and compensation, cause, pathophysiology, clinical manifestations, diagnosis, and treatment. Firstly, we need to know what intracranial pressure is. As we can see from this picture, the main contents in the cranial cavity are brain tissues, cerebrospinal fluid, and blood, together making the volume of a normal adult's cranial cavity constant relatively, namely 1,400 to 1,500 milliliter. The volume of contents in the cranial cavity is adapted to that of the cranial cavity, so as to maintain a constant pressure in the brain, called intracranial pressure. The intracranial pressure normally ranges between 17 to 200 millimeter water in adults and 15 to 100 millimeter water in children. The clinical pathological syndrome triggered by intracranial pressure exceeding 200 millimeter water in adults or 100 millimeter water in children due to various reasons is called ICP, most frequently measured by lumbar puncture in clinical practice. Another method is ventricular puncture and drainage. Thanks to the advancement of technology, we can now direct the dynamic changes of pressure through intracranial pressure monitoring. It is known that intracranial pressure is not a constant value, but fluctuates within a small range and subject to the effects of blood pressure and respiration. The volume of human brain tissue is unchanged, and that of blood and cerebrospinal fluid can change. There are two ways for regulating the pressure. One is to make the intracranial venous blood squeeze out of the blood circulation outside the skull, which means acceleration of venous return to lower the intracranial pressure. Another way is the regulation of cerebrospinal fluid. The cranial cavity and the subarachnoid space of spinal canal are interconnected. In case of increase of intracranial pressure, the cerebrospinal fluid in cranial cavity will be squeezed into subarachnoid space of spinal canal. The slow regulation mechanism of cerebrospinal fluid works when the intracranial pressure goes lower. The secretion of cerebrospinal fluid increases and the absorptions decrease, thereby increasing the downward intracranial pressure. When the intracranial pressure increases higher than normal, the secretion of cerebrospinal fluid decreases and the absorption increases, thereby lower the intracranial pressure to compensate the increased pressure. As the pressure regulation of cerebrospinal fluid is the most important compensatory way of intracranial pressure regulation, is this pressure regulation and compensatory mechanism infinite? As it can be seen from the pressure profile, the compensation is not infinitely variable. When the pressure increases to a certain extent and the volume increases by, for example, 5%, the intracranial pressure rises to a critical value, before which it varies slightly following increase of volume, and upon the volume increases by 8% to 10%. The intracranial pressure rises steeply following every further little increase in volume. Under the circumstance, if the intracranial pressure remains unchanged, it will continue to worsen and may result in cerebral hernia and death. What are the causes of ICP? The first one is the changes of volume of contents in normal cranial cavity. As we know, the contents in the normal cranial cavity include brain tissues, cerebrospinal fluid, and blood. For example, there are few of cases in normal cranial cavity, such as the increases of brain tissue caused by encephalodema, increase of cerebrospinal fluid due to hydrocephalus, increase of blood flow due to malformation of large flow vascula, venous return blockage due to thrombus of venous sinus, increase of abnormal cranial contents including hematoma, tumor, and abscess. The intracranial pressure increases when these diseases occur. Thirdly, in addition to the increases of the brain contents, the volume of cranial cavity getting smaller also leads to change of intracranial pressure. For example, the congenital aplasia, craniosteogenesis, and basilar invagination will lead to a smaller volume of cranial cavity, which give rise to a higher intracranial pressure. As for another acquired factor, the reduction in the contents of the cranial cavity in the aftermath of large depression in the skull also causes an increase in intracranial pressure. What are the pathophysiological changes follow the increase of intracranial pressure? What factors will affect the increase of intracranial pressure? The first factor is age. People at different age have different tolerance degree against ICP. For the infants in particular, whose sutura of skull are not closed, when the intracranial pressure increases, the bone sutura will crack, and the compensatory ability is stronger. And for the aged people experience cerebral atrophy, the volume of cranial cavity is relatively larger, also making the compensatory ability stronger. The rate of lesion expansion is also a factor. As mentioned above, the compensatory mechanism of intracranial pressure, represented by obstruction and transfer of cerebrospinal fluid, is divided into rapid compensatory mechanism and slow compensatory mechanism. When the lesion expands extremely quickly, only the rapid compensatory mechanism works. So the effect of intracranial pressure compensation is relatively poor. When the lesion expands slowly, both the rapid and slow compensatory mechanism work, and the patients will develop a higher tolerance against increase of intracranial pressure and the volume with a better effect of pressure compensation. What's more, if the lesion is located in the midline or posterior cranium, in addition to the increase of intracranial pressure caused by the lesion itself, hydrocephalus may also be caused at this time, together bringing the increase of intracranial pressure to a higher level. If the lesion is located near the large intracranial venous sinus, in addition to the increase of intracranial pressure caused by the lesions itself, the lesion may compress the venous sinus and cause venous return disorder, thus leading to further increase of intracranial pressure. For lesions of the same size, the varying degrees of encephalodema also cause different level of increase of intracranial pressure. And the last factor is systematic disease. For example, electrolyte balance, hypoxia, ischemia, and uremia may cause aggravated edema, thus leading to a higher ICP. What are the consequences of ICP? The first consequence is reduction of blood flow. According to this formula, we can see that when the intracranial pressure increases, the cerebral perfusion pressure decreases, and then the cerebral blood flow decreases, thereby leading to cerebral ischemia and anoxia, and brain edema. Further aggravation of encephalodema will increase intracranial pressure, which will lead to a vicious circle, thus aggravating cerebral ischemia and anoxia. If the vicious circle continues, the cerebral hernia will occur, ended by patient death. Fourthly, the change in vital signs, namely Cushing's reaction, is also a consequence. The Cushing's reaction classically presents as an increase in blood pressure, slow breathing, and slow pulse, sometimes accompanied by high body temperature in response to the intracranial pressure increasing to near diastolic blood pressure (DBP). Fifthly, gastrointestinal dysfunction and gastrointestinal bleeding are also among the common complications. The increase of volume will cause disturbance of the autonomic nerve function center of the hypothalamus, thus leading to bleeding, ulcer, or even perforation of the digestive tract. Sixthly, a rare but serious complication is neurogenic pulmonary edema, accounting for 5% to 10%, manifested by tachypnea, excessive phlegm, and excessive frothy blood sputum caused by enhancement of activity of the adrenergic nerve following an acute increase of intracranial pressure. What are the clinical manifestations of ICP? The most important clinical manifestations of ICP are headache, vomit, and papilledema. The headache would be severe and the vomit is projectile. The ICP, primarily chronic ICP, would be identified upon showing the three symptoms together. The acute ICP is only manifested by headache and vomit without papilledema. Changes of vital signs, Cushing's reaction, as well as consciousness disorder, which progressively worsens from sobriety, somnolence, light coma, and finally to coma are among major symptoms. Other symptoms and signs are called focal symptoms, triggered by ICP and related to the site of lesion. For example, patients with brain abscess may develop high temperature. Patients with acute injury may suffer local pain, and patients with tumor may develop hemiplegia if the tumor is located in the central and aphasia if located in the cerebral language area. Back to the diagnosis of ICP. One important basis is the patient's medical history. That is to say, if the patient has a history of hypertension, we need to consider the possibility of hypertensive cerebral hemorrhage, and for the case with injury, we need to consider whether there is cerebral concussion or intracranial hemorrhage caused by the injury. If the patient is found with headache that slowly grows severe, it may suggest a tumor. In addition to previously mentioned three major symptoms, changes in vital sign, progressive consciousness disorder, and focal symptoms are also clinical manifestations. Auxiliary examination is important in identifying the ICP and determining its severe degree, as well as its cause. CT examination is the most frequently method used for cerebral hemorrhage and identifying hematoma, site of contusion, and site of hematoma, thereby preliminarily screening patients with tumor. As for neoplastic lesion, MRI has more advantages, and cerebral angiography is mainly used to identify the ICP caused by intracranial vascular malformation and thrombus of venous sinus. As we mentioned before, lumbar puncture is a good way to measure cranial pressure, but it should be noted that when the intracranial pressure rises significantly and the intracranial pressure is highly suggested, lumbar puncture is prohibited as radial hernia may be triggered during the practice and lead to the unconscious and even death of patients. What are the treatment methods of ICP? The first method is to observe vital signs, namely observation of consciousness state and pupil changes to be informed of the change in patient's condition. The second method is to keep respiratory tract unblocked and practice tracheotomy when necessary so as to avoid ischemia and anoxia and maintain liquid balance. In general, we need to keep the amount of liquid intake less than that of drainage to keep the patient in a slightly dehydrated state. The third method is to maintain the balance of water and electrolyte and keep a normal bowel movement and do not practice high position animal, which may cause the ICP to worsen and even death. The fourth good method is to monitor the intracranial pressure, which can especially guide the treatment on patients satisfying the indication. The best treatment method is etiological treatment. For example, remove tumor, clear hematoma, or practice external drainage, or short treatment of cerebrospinal fluid for patients with hydrocephalus. For the patients with a mild increase of intracranial pressure or needs to wait for some time to have an operation, drugs would be an auxiliary method. Dehydrating agent, diuretic and hormone are commonly used drugs, especially 20% mannitol, which has a rapid and effective dehydration effect. The glycerol fructose with slightly weaker dehydration effect would be a preferable choice for patients with a renal dysfunction and mild increase of intracranial pressure. The major diuretics used are furosemide and hydrochlorothiazide as an auxiliary drug, and dexamethasone is mainly used to reduce vascular inflammation. The hibernation mixture is mainly used to lower the body temperature of the patient, decrease metabolic rate of brain, reduce oxygen consumption of brain tissue, and increase tolerance of brain against ischemia and hypoxia and reduce swelling, thereby significantly lower the intracranial pressure of patients, especially those with severe and critical brain injury. The fifth method is auxiliary hyperventilation, which may lower the cerebral blood flow by increasing the emission of carbon dioxide and using self-regulation function of blood vessel of brain so as to lower the intracranial pressure. Hyperventilation is mainly adopted as a temporary treatment in operation. For example, in case of encephalocele occurring during an operation, the anesthesiologist may be auxiliary hyperventilation to lower the intracranial pressure and help surgeon complete the operation. That's all for today's class. Thank you.